Okay, thank you very much for having me today. I look forward for next year when I'm able to give this talk in person, but we will have to do it virtually this year. I would like to thank the organizing committee for allowing me to share with you my thoughts and my clinical experience with skin cancer and later on with lung cancer. This topic was selected to raise awareness about what skin cancer looks like, what the risk factors for skin cancer are, and what treatments are available in the community, whether it's in the dermatologist's office or in the office of medical oncology like myself. My name is Camila Dami. I'm a medical oncologist with City of Hope in Upland. And so I will just go straight to the point and tell you what we're going to be talking about today for skin cancer. These are the topics that we're going to be reviewing today. We're going to talk about the main types of skin cancer, what the symptoms are, what the most common symptoms are, the risk factors, the ones that are common sense and the ones that are not recognized in the community. Then we talk about diagnosis and the revolution in the treatment options that we have, whether it's what the surgeon does or what we as medical oncologists do when this cancer is trying to spread. So I like to lump skin cancers into two major buckets, the bucket of non-melanomas and the bucket of melanoma skin cancer. Evidently, the most common ones are the non-melanomas, and the two main ones are basal cell carcinoma and squamous cell carcinoma. Of course, if you do your Google research, you'll see a lot of rare subtypes of those, but the most common, the bread and butter skin cancers are the basal cell and the squamous cell carcinoma. This is a picture of how a basal cell cancer looks like. It occurs with the aging process. It looks pearly. It feels like it's waxy. It's the most common form of cancer in the United States. This is the skin growth that bleeds easily. It grows over several months to even several years. I rarely see those myself as a medical oncologist in the office because these cancers rarely spread. So when patients recognize a change in a skin lesion like this one, they see their primary care doctors and they get referred to the dermatologist. Same applies to the squamous cell cancer. It's the second most common type of skin cancer in the US. This one is more flat in appearance. It's less waxy, it's less pearly, it looks red. Squamous is the thick part of the skin. So this is what protects us from environmental exposure. So that's why, somebody develops thick skin, it's because of that squamous part. It's really tough. So when that becomes cancer, it's a little bit rougher. It's not rubbery. And it's more common in fair-skinned people. The main risk factor for squamous cell cancer is, again, UV light exposure. Those types of cancers can also spread, but it's very rare. What are the common themes with those non-melanoma skin cancers? The common themes are age and exposure to UV therapy and duration of exposure to sun and UV therapy are the main risk factors. And just like any cancer, the immune system plays a major role in controlling cancer cells in our body. So believe it or not, all of us, if we're healthy, as I speak right now, I have cancer cells in my body, but my immune system recognizes those cells and keeps them at bay. So naturally, when the immune system weakens, whether it's from infection or medication, then there's a higher risk of developing those skin cancers. They rarely spread, and these are not the types of cancers that I see in my clinic as a medical oncologist. Those patients, they end up in the dermatologist's office, and they are the dermatologist will perform something called Mohs surgery. Don't let the word surgery mislead you into thinking general anesthesia and all so on and so forth, but it's a very delicate type of resection of those tumors that's done under the microscope, and it's a very valuable skill that a dermatologist has to practice because some of those cancers, they grow on the face. And so it's a very delicate procedure, if you want, that we refer to as Mohs surgery. Malignant melanoma, on the other hand, is what I often have to tackle and what I often see in my clinic. So remember, we have two buckets, the non-melanomas, the squamous and the basal cell carcinoma, and now the melanomas. Now, contrary to popular belief, it's not just the cancer of the mole. Most of the times it does start in a visible mole, but melanoma is a cancer of special cells called melanocytes, and these are the pigment cells. Now, you can see the change in the skin color, that's the visible pigment, but we have them all over the body, and sometimes you don't see the quote-unquote mole, but that cell can become cancerous. Now, if you do have a mole and you notice a change in the size, the color, the symmetry, if that mole is bleeding or developing an ulcer on its surface, then you suspect that that mole is turning into a cancer of the mole or melanoma. It affects younger people. So with basal and squamous, like I said, it's UV exposure in time. So it's patients who are older, they had more years of exposure to sun. With malignant melanoma, it's a cancer that affects younger patients. And we, in spite of all the advances in technology, it's the very basics that have not changed with time. A melanoma, when it first declares itself, you notice a change in the size, and you notice an asymmetry. The borders become irregular, the color changes, and so those are what we call the ABCDs of melanoma. So again, you don't need a PET scan, you don't need a high definition microscope to recognize it. It's something that you see with your own eyes. The risk factor, the common risk factor for melanoma, the one that's recognized across the board, is UV light exposure. But I want to bring to your attention the not so commonly recognized risk factors that I would like to raise awareness about in the community, and those are genetics and Parkinson's disease. So about 10% of melanomas are inherited, and they run in families, and that is something that we need to be aware of. So if person has a parent or a sibling or a grandparent who's had a melanoma, those patients should be a little bit more careful, because now we have a better understanding of the genes that drive the growth of this cancer. And Parkinson's disease, again, because we know that these neuromuscular disorders also are driven by DNA abnormalities. Certainly, it's still a black box. It's still a mystery for us. But just from observational studies, we know that having Parkinson's increases the risk of having a melanoma. It's not very clear, but it's a clear observation at least. It's not very clear why that happens. This is what a melanoma looks like. It's darker than the squamous. The squamous cell is red. The basal cell, again, is rubbery, waxy. The melanoma is darker. It's a dark pigment. And, it's irregular in size. So that's how it commonly looks like. So those are the cancers that, unlike the non-melanomas, those are the cancers that can actually spread. And a small skin melanoma can spread to the liver, the lung, the brain. So these ones we all take very seriously. So if you do notice something like that, and you go to the dermatologist. The first thing the dermatologist is going to do is they're going to biopsy it. If it comes back as melanoma, they're going to remove it. And this is where things become a little bit tricky, because unlike the non-melanomas, which are superficial cancers, melanomas, they can run deep in the skin. Melanomas can be thicker if you want. And so that thickness determines the stage of the melanoma. So as much as we like to pay attention to size to recognize the melanoma, what's more important for us once we know that the melanoma is there is how thick it is, because the deeper it goes into the skin, the higher the chance that melanoma is going to spread. And it can spread locally in the skin. It can spread locally in the lymph nodes, and the lymph nodes are glands that we all have. We have those glands behind our ears, neck area, chest area, belly area. And if cancer is trying to spread those glands, or lymph nodes will filter them. So the thicker the melanoma, the higher the chance of it going to those lymph nodes. That's what the dermatologist and the surgeon will do. They'll remove the whole thing, not just shave it. They'll go deep and resect the melanoma, and they'll tell us a measurement of the thickness, and then the thickness. And then the surgeon, if it's thick enough, he will go after the gland that's closest to that melanoma and also remove it. So really, surgery is what tells you what stage the melanoma is. They'll remove it and tell you if it's in the lymph node or not. If it's a early stage melanoma, we typically don't do imaging, but if it's going to the lymph nodes, we do. We do CAT scans and PET scans to make sure it's, it hasn't gone beyond the filter to organs like the lung and the liver. So this is what the surgeon does. He or she will remove the tumor. They'll inject it with a dye to see which lymph node is closest to it and which one is connected to it. They will remove the lymph node or sentinel lymph node, the one that's guarding the melanoma. They will study it under the microscope to tell us if it's there, if the cancer made it to the node or not. So unlike the other skin cancers where you take it out, you're done, with melanomas, it's different. If you take it out and you find out that it was trying to spread, then that's where we come in as medical oncologists by offering adjuvant treatment. Adjuvant means, if you want, post-operative treatment. So the revolution that we've had in the last few years for those aggressive skin cancers is immunotherapy. I started this presentation by telling you that we all have cancer cells in our body. Our immune system manages to keep them at bay, but every now and then they escape the immune system, they grow and they spread. Well, now we have immunotherapy, a type of treatment that stimulates the immune system to attack the cancer cells. So this immunotherapy doesn't attack the cancer cell itself. It tells the immune system to attack the cancer cell. And that is, again, a remarkable improvement, because we can now not only treat, but sometimes even cure cancer that has spread, which is used to be a rare thing. The same concept applies even when the horse is out of the barn and the cancer has spread. That's when we say at stage 4, it spread to other organs. In that situation, we have immunotherapy and we have chemotherapy pills that can control the cancer, slow it down, and sometimes, not all the time, make it go away. So I hope that I was able to share with you some of the newer concepts in how we approach skin cancers. I hope I was able to make you more familiar with the terminology that we use in the universe of skin cancers, and that there are new and modern treatments. I wish this conference was in person. I would give you a chance to ask me any questions that you have, but for now, I will just disseminate the knowledge and Thank you very much for this opportunity.